system. And one of their main functions is the exchange of gases in the body, which are essential for homeostasis. And you know, homeostasis is the state or the balance in where it's just perfect. There is no ups or downs, so it is just the perfect balance. Other primary function is the intake of oxygen, which is needed for metabolism and release of carbon dioxide. Carbon dioxide is the waste product of metabolism. And intake is when we inhale. Also, other functions of the respiratory system is the maintenance of the acid balance, which keeps the pH between 7.35 to 7.45, which is the normal range. It also maintains body fluids, the concentration of CO2, and the blood concentration of carbonic acid and hydrogen ions. It assists with the speech produced as air moves out of the lungs and passes over the vocal cords. So know the main functions of the respiratory system. There are other systems that influence the respiratory system, and one of them is the central nervous system, which is influenced by the concentration of gases. It regulates the rate and depth of each respiration. The cardiovascular system also, it is influenced the respiratory system because it is responsible for transporting the gases throughout the body. The musculoskeletal system is responsible for protection of the structures of the respiratory system, and muscular activity allows for rhythmic movement of the thoracic cavity, leading to the exchange of oxygen and carbon dioxide. So have an idea of what are the main functions of the respiratory system, which they are a lot, and most of them are essentials. There are other structures that compose the respiratory system, and we are just going to go briefly over it, and the ones that you need to know, I will mention. So the respiratory system is divided in upper and lower respiratory tract. On the upper respiratory tract includes the nose, the mouth, the sinuses, pharynx, larynx, and proximal trachea. The lower, let's go over the pictures because I think it's easier. No, it doesn't show there. Where is it? Well, I guess, eventually we will see it. But fortunately, it's very these are very common structures that you already study in your anatomy and physiology class, so it's not terribly difficult to visualize them. On the lower respiratory tract, there is the distal trachea, bronchi, lungs, pleural membranes, muscles of respiration, and the mediastinum. The respiratory cycle, this you need to know, respirations and breathing are used interchangeably. So when we say respirations and or we say breathing, it is the same thing that we are referring as to the respiratory cycle. And the movement in the respiratory cycle is the movement of air in and out of the body, which means inhalation and exhalation. The thorax is called the chest, which is a closed cavity containing the structures needed for respiration. The mediastinum includes the heart, trachea, esophagus, major blood vessels, and pleural cavities. And all of that is nice to know. Thoracic cage includes the bones, cartilage, muscles of the thorax, and that is nice to know. Trachea is 16 to 20 rings of hyaline cartilage. The bronchi, main bronchus enters each lung at the hilus. The terminal bronchioles less than 0. millimeters in diameter, and that is this is nice to know. The lungs you need to know. Alexis, make sure you clock in. Okay, so lungs are cone-shaped, elastic, spongy air-filled structures and pleural cavities. And of course, the right lung has 3 lobes and the left has 2 because of the heart that needs a space for the heart there on the left side. Pleural membranes, thin double-layer serous lining. They are important because they have surface tension created by fluid and negative pressure between membranes to keep the lungs expanded. Mediastinum, middle section of the thoracic cavity, surrounded by the right and left pleural cavities, and that is nice to know. Muscles of the respiration includes the internal and external intercostal and the accessory muscles of the neck. The accessory muscle of the neck, the abdomen, and the chest, they are significant because they play a major role during the stress and pathology, which means whenever the person is having any type of respiratory distress, the things that we as nurses notice immediately will be the use of accessory muscles of the neck, which means like the clavicles. When they are having problems, you will see that the clavicles kind of sunk and the abdomen. Normally, the breathing that we do as an adult is upper breathing. It's like chest breathing, not abdominal. If it is abdominal, it is considered that the person is in distress. Children have abdominal breathing, but adults, it is considered a sign of distress if they breathe that with the abdomen only. Know these terms: eupnea, that is regular, even rhythmic pattern of breathing. So if you are eupnic, that means you have a normal respiratory cycle. Know dyspnea, which by now you already know that. This is changes in this pattern producing shortness of breath or difficulty breathing. So know those terms. There are some landmarks, and we already know that landmarks are imaginary lines that help us in order to locate certain structures. So, and we will see this in a few minutes, but these are the bony structures that are considered landmarks of the lungs: the sternum, the angle of Lewis, clavicles, ribs, and vertebral column. And I will point out what you need to know later on. Horizontal and vertical lines, the anterior, posterior, and lateral. And I think those we can see it in the, okay, so 17. Okay, here we are. So these are the landmarks of the anterior thorax, and this is the anterior view, which means the front. Landmarks of the anterior thorax. Repeat it. The landmarks help the professional nurse to develop a mental picture of the structures being assessed. And of course, this is the sternum, this big bone or breastbone that it is right in the front, and it has 3 parts. One is the manubrium, which is the upper part, and then see the location of the sternal angle of Lewis. This is significant. It will be significant on the when we study the heart, but at the moment, just know that it is part of the sternum. And this is the body, the big piece in the front is the body of the sternum. And the last part is the xiphoid process. Remember, whenever you are going to insert a nasogastric tube, you measure it from the tip of the nose around the ear and all the way to the xiphoid process. There at the bottom, there are the costal angle and clavicles. Of course, you already know where they are, but make sure you have a real good mental picture, because these are the accessories muscles that will indicate if the person has a problem, has a breathing problem, or is in distress, because those clavicles will raise up. Get a mental picture of the acromion process of the scapula, and see how you have to make sure that you understand what is second intercostal space, third intercostal space, and that is the rib that it is in between the two ribs. Like for instance, second intercostal space is between rib 2 and rib 3. And the ribs, as you can see, they are numbered. It is on the left side. There are 10. And we will see the other ones in the next slide. So get a mental picture of those structures. This is the landmarks of the anterior thorax, left lateral view, showing relationship of the anterior landmark to the vertebral column. And you can see, even though it's a little bit hard to see, but it's at least it's noticeable in my computer, like T1, which means thoracic, T1 all the way to T12. You also have part of the left common carotid artery, the jugular notch, the heart, the diaphragm, and the abdominal aorta. This is the back, which is the posterior thorax, shows the relationship of the anterior landmarks to the vertebral column. And so we can start with the clavicles, the scapula. And again, you see the ribs in the back. You have 12. The last ones they are called floating ribs. C7 and the spinous process of T1. Again, that is nice to know. Just get the mental picture. That's what you need to know, because when the scenario is explained to you, it will say the right mid-clavicular line, so you have to focus on that area. Again, this is the anterior, and these are the landmarks. You can say the right mid-clavicular line, like for instance, you heard some type of crackles or something, and you can describe it exactly where you found it. And by the axillary line, there is the right anterior, left mid-clavicular line, vertical from the midpoint of the clavicle. And of course, the mid-sternal is the middle. This is the lines of the posterior. And you can see again, wherever the structure is located, that's how they name that imaginary lines or landmarks, like the left scapular line, the left posterior line, and then if it is a left, it has to be a right. And you can see in the middle, the vertebral center along the spinous processes from C7 to T12. Nice to know. Lines on the lateral, posterior axillary line, vertical from the posterior axillary fold. And then there is the middle with mid-axillary line. Lobes of the lungs, posterior view, upper lobe, left oblique fissure. Again, for this, you just need to get an imaginary, get a picture of this. So when you are talking about where the left lobe is located, you have a mental picture of it. This is the anterior, these are the lobes of the lungs on the anterior view. This right upper lobe. Just right lower lobe. So get a mental picture of that, because when you are assessing or auscultating, the lungs, you know more or less where they are. Left mid-clavicular line goes all the way down, and the left lower lobe, as well as the left upper lobe. lateral views of the lobe. So on the left lung, you can see the left upper lobe and the left lower lobe. The left lower lobe is almost on the mid-axillary line. And again, okay, let me see if we missed anything. So we are on 30 now. I think we left on the 17. Okay, they just list the same structures that we went over with the pictures. Okay, so we didn't miss anything. Okay, so again, remember every system that we study, we have to go over special considerations. And again, whenever we have talking about the lungs, age is of course, age has a very powerful influence in almost every system, as well as in the lungs. And we will describe that in a few minutes. Another special considerations that we have to have is the developmental level, the race. There are some diseases that are more prevalent in certain races, ethnicities, work history, living conditions, socioeconomic status. Remember, when we talk about a socioeconomic status, we always refer that to whether the individual has access to healthcare. In other words, has medical insurance. Otherwise, they won't have preventive care because they're just too expensive. And emotional wellness, that absolutely will impact our overall health. Okay, according to Healthy People 2020, one of their goals is to prevent asthma and COPD through the reduction of exposures to known hazards, identify new potential threats to respiratory health, like coronavirus, for individuals experiencing asthma or COPD, ensure provisions of effective treatment and reduce limitations caused by the respiratory disease. And the next slide is nice to note. We don't have to concentrate on this or memorize that. Nothing on infants and children. Nothing on infants and children. Pregnant female, we have to know that when the person is, the female is pregnant, their muscles and cartilage of the rib relax, and so their inspiratory capacity increases and the expiratory reserve volume is decreased, and total lung capacity remains the same, and the oxygen consumption can increase 20% whenever they are pregnant. And there is always a mild respiratory alkalosis. And again, this affects every woman in a different way, some to some degrees that they need to see the doctor. Most of them, they don't. But older adult, this is the one that we concentrate. So the way that the older adult is impacted by whenever we are talking about the respiratory system is because there is a decrease in respiratory efficiency overall in the elderly. The lungs lose elasticity, so that it is more difficult for them to breathe or take a deep breath. The skeletal muscles weakens, and there are changes in respiratory depth. There is a decrease in cough ability, decrease. Most of them, they have a decrease, but there are some that they have also an increase in respiratory rate. We know that the respiratory rate is 16 to 20, and they might have like 22, 24, something like that. Anxiety and physical exertion can cause significant demands, for oxygen. So sometimes if the person gets anxious or they do physical walk for a while, they require more oxygen. There is an increased effect on infection because their immune system decreases, so they are more prone for respiratory infections. Related to psychosocial considerations, Exacerbation of respiratory problems due to psychosocial considerations include stress. If the person is very stressed, of course, their respiratory problems may get worse. Anxiety is another factor that will affect their respiratory, that will lead to respiratory problems. Fatigue, if the person is extremely fatigued, and pain, of course. All of the above, the stress, anxiety, fatigue, and pain can cause significant demand on the respiratory system, and infection can lead to a devastating effects and physiological alteration with gas exchange. Certain drugs used in the treatment of respiratory disorders may cause hands to tremble. So you might think sometimes that the person might be a drug addict or maybe might have Parkinson's disease, but you also have to take into consideration that some medications cause side effects like the bronchodilators, and many people who have problems with COPDers, will take asthma will take bronchodilators, and that as a side effect makes the hands tremble. Know that cultural and environmental considerations, race, remember we mentioned that certain diseases are more prevalent in certain races, tuberculosis, asthma, COPD, sleep and sleep apnea, they are greater in the non-Caucasian population, and that is in the USA, not necessarily in Europe or some other, So asthma, COPD, sleep, and sleep apnea are greater in the non-Caucasian population. Ethnicity, the removal of religious icons may impact their, their feeling that the person who is trying to remove it or remove them are not being considerate about their culture. Because some of them might have some type of icons or some types of religions, medals or something like that. And we might try to remove them because sometimes they might be on the way, sometimes because they might not very clean. So again, we have to be considerate of that, and always ask if you don't know. Presence of allergens, like non-allergens. Anyone who has asthma, they should know what are the triggers, what are the triggers in order to prevent an attack. Same thing, if you are allergic to something, you always try to avoid it so you won't have any problems with it. Socioeconomic status, no access to health care. Incidence of respiratory disease, people from Puerto Rico, American Indians, Alaska Natives, etc., they are more at risk for respiratory diseases. And geography and environment also has a big impact on the lungs, like temperature, moisture, humidity, altitude. The temperature in the environment will cause like the cold. If you go to an area that it is extremely cold, then it will be vasoconstriction. And what happens with vasoconstriction to the blood pressure? Does it go up or down? You can point your finger up or down. Yes, that is correct, Joanna. Yes. Vasoconstriction, same thing with the smoking. It will increase the vasoconstriction of the veins, and therefore the person will end up with high blood pressure. When there is moisture and humidity in the environment, the person will tire easily, increasing the need for more oxygen. That's why in some areas where there is such a great amount of humidity, sometimes they take a nap during the day because they tire easily. The altitude, as altitude increases, the partial pressure of oxygen decreases. So the person must adapt by increasing rate and depth of the respiratory cycle. So those definitely affect people the athletes, whenever they go to compete in an area of high altitude, they go with a week or a couple of weeks in order for them to adapt to the increasing rate and depth. Otherwise, they cannot compete. Air pollution with the smog, industrial wastes contributes to respiratory problems in all people. Definitely so. I agree completely on that. Focus interview, always consider the patient's ability to participate. If the patient is experiencing dyspnea, cyanosis, difficulty with the speech or anxiety, attention must focus on the relief of symptoms and restoration of oxygenation. And we don't have to concentrate on these focus interview questions because you do that on your assignments, ATI assignments. Assessment, you need to know the assessment techniques of the respiratory system, which is inspection. Inspection is for all the systems. Then for the respiratory system, it is inspection, palpation, percussion, and auscultation, in that order. So when we inspect, what do we look when we are assessing the respiratory system? We inspect the anterior and posterior thorax, and we check. Remember, we divide always, whenever we assessing the patient, we always divide the body and the right on the left, like a line all the way from the head all the way to the toes, you divide it in right and left. Then you check the shoulders. Is there symmetry there? Because it is significant that one shoulder is higher than the other. So the symmetry configuration is that, does the chest look normal, or is it barrel chested? You don't even have to count the respiratory rate to decide or to assess that the patient is breathing with difficulty or rapidly or very slowly. Just by observing it, you can get that information. And when we palpate, what do we palpate? We palpate the ribs, the intercostal spaces, and we do also respiratory expansion and tactile fremitus. And we will talk about that in a few minutes. Okay, this is how you position the patient whenever you are going to assess the lungs. The best way to assess the lungs is with the patient sitting down. Whenever you are going to do your practicum, you should do your practicum in a chair, and the only time you get the patient to lie down is whenever you are assessing the abdomen. But other than that, you can do very well all the systems with the patient sitting up in a chair. Patient should be in a sitting position. Patient should only have a gown or drape, stand in front of the patient. Lighting should be adequate to detect color differences, lesions, and chest movements. Explain procedure and ask the patient to breathe normally. This is during observation, during the assessment. But whenever you are auscultating the lungs, you must instruct the patient to take a deep breath every time he or she feels your stethoscope. But when you are just inspecting, you tell the patient, just breathe normally. I will be just observing you for a few seconds. To inspect the chest for configuration, the adult transverse diameter is twice that of the anterior diameter. So AP equals to T. AP is to T, 1 to 2. 1 to 2. Know that. And you understand when they said anteroposterior diameter, they are talking about the front compared to the side. Of course, the side shouldn't be as wide as the front, right? Because if that is the case, then it's not normal. Okay, so when you are palpating, the reason why you palpate, whether you can feel any lumps or bumps or any type of tumors or maybe there is tenderness, that is the reason why you palpate. So this is how you will palpate. See the numbers? You will go on the right shoulder, 1 one. So 3 times in 3 areas, as you can see in the picture. Then you go in the other shoulder, and you do it 3 times, like 2, 2, 2. And then you descend 2, 3, 4, 5, and 6. So those are the areas that you will be palpating. 7, 8, 9, and 10. Then down again, 11, 12, 13, 14, 15, 16, 17, and 18. So those are the areas that you will need to palpate. Explain that you will be palpating or touching the patient's back to determine that there is, and if there is any area of tenderness, to inform you if pain or discomfort is felt in any area touched. Pain may occur with fibrous tissue and underlying structures like the pleura. No crepitus. Crepitus is a crunching feeling under the skin caused by air leaking into subcutaneous tissue. No crepitus. No palpation for respiratory expansion. When you do your, this is important for your quiz as well as the final, as well as for your practicum. You need to know how to test the respiratory expansion. And it seems when we are explaining it through reading, it seems very difficult, but it isn't at all. You just put your hands on the chest, on the back of the patient's, on the back of the lower, just where the ribs end, right there. You just place your 2 hands on the patient's back, lower back, and then the thumbs should be close to the spinal cord, and you kind of get closer your thumbs and pinch a little bit of the skin. And then when you are pinching that skin, you ask the patient, take a deep breath. When the patient takes a deep breath, your fingers, your thumbs move at the same time. At the same time. You pinch some skin between your thumbs, ask the patient to take a deep breath. The movement and pressure of the chest against your hands should feel smooth and even. Your thumbs should move away from the spine and skin as smoothly as the chest moves with inspiration. Unilateral decrease or delay in expansion may indicate underlying fibrotic or obstructive lung disease or pneumothorax. So know that. That is the reason why you test for, you palpate for respiratory expansion. And you don't need to do it for the purposes of the of time. When you do your practical, you only do the back. You don't need to do the front. But the front should be the same as the same way that you do the back. Okay, so now you are palpating for tactile fremitus using the metacarpophalangeal joint area. Fremitus, notice, is a palpable vibration of the chest wall when the client speaks, and it is stronger over the trachea and diminishes over the bronchi, and it is almost non-existent over the alveoli. Use one palmar surface of the hand at the base of the finger's surface. Ask the patient to repeat 99 or 1, 2, 3 in a clear, loud voice. If you find a decreased fremitus, which means if you don't feel the vibrations, it could be because the patient spoke in very soft voice, or there is a thick chest wall, or there is obesity or underlying diseases, such as COPD, pleural effusion, fibrosis, or tumor. So notice decreased fremitus, why it might be, and increased fremitus, it occurs with fluids in the lungs or infection. And make sure that you know that you use the metacarpophalangeal joint area, which is the base of your fingers, and that is you are palpating for tactile fremitus. So know that. Okay, so these are the assessment techniques, and so we will see it here. This is how will you percuss the posterior thorax. Again, they say the name of place the pleximeter in the intercostal space parallel to the ribs during percussion. And it seems like it's terribly difficult when you just read it, like too complicated. But again, it is almost the same technique when you are doing the palpation, like on the shoulders, right on the top of the shoulders. You will go in three areas: one, 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 and then two, two, two. And the only thing you do is you just place one of your fingers down on the area that you are going to percuss, and with your other hand, you just tap on that area. And what it does, it produces different sounds depending on the area that you are touching, or depending what area you will be touching. Like for instance, percussion over solidified or fluid-filled areas will yield a dull sound, versus percussion over a bone, which it will yield a flat sound. So that is, by doing this, it will tell you whether there is dull sound, could be due to maybe some type of, there is fluid there, or maybe there's a tumor. But if you percuss the bone, like the shoulder blade, that will produce a flat sound. We are not doing the diaphragmatic movement percussion or measuring it because usually it is not done it's considered an advanced technique. So no diaphragmatic movement percussion, but yes, you do the pattern for percussion of the posterior thorax. So no diaphragmatic movement percussion. And this is just to assess whether there is an asymmetry in the diaphragm, because it may indicate diaphragmatic paralysis or pleural effusion on the elevated side, and it involves 2 steps. Again, it is more considered an advanced technique, so usually you don't do this. I never did this in critical care or ED. So the 2 steps is like percussing, how she's percussing right there at the lower back, and then the other way is to measure wherever she or he found resonance or dullness. So ignore that. Assessment techniques: auscultation of the posterior thorax for tracheal, bronchial, bronchiovesicular, and vesicular. These are the normal sounds. For our purposes, and while you are in the skills lab as well as in the SIMS lab, you are only to auscultate. See how, according to here, you auscultate 18 times. Okay, in real life, you only auscultate 8 times, or 8 areas in the back, which means below the clavicle, and of course, like right below on, like on 5, you see 5. So right there, you will start by doing that, 5 and 6, and you compare. Of course, you have to be close to the spinal cord, as you can see it right there. And so, 5 will be, you will start right there. So that will be 1, 2 on the other side, and you compare number 5 to number 6, and they should be equal. You shouldn't have any difference in the breathing pattern, or the sounds. Like you shouldn't feel crackles on one side versus the other one. So that's why you will say breath sounds clear bilaterally. Then you will go to 7 and 8. 8 and usually 7 and 8, which is that one. And that will be 6 there. And then on the sides, like 16 and 15, that will be your 8 areas. That would be your 8 areas. The reason why we don't do that is because most of the times when you will see when you practice with your patient or somebody practices on you, and every time that you feel the stethoscope, you have to take a deep breath. By doing that, sometimes the persons feel lightheaded and they end up, kind of losing consciousness. So, and most of the times the patients are elderly, and so they cannot do that many, 18 times, can you imagine? So that is how it is done. So in the skills lab as well as the SIMS lab, you are expected to do to auscultate 8 areas in the back and 6 areas in the front. And so asking the patient to put the arm over the head or lean forward to the opposite side is often helpful in assessing the chest wall during auscultation. Always you should monitor the patient's breathing because in order to prevent hyperventilation. Because when you take a deep breath so many times, you can end up with hyperventilation. And these are the normal breath sounds that we mentioned earlier. The sound is tracheal if you are auscultating over the trachea. The ratio inspiration to expiration is inspiration or expiration is greater than inspiration, and the quality is harsh, high pitch, bronchial next to the trachea, superior to each clavicle, and in the first intercostal space. Expiration is greater than inspiration, and it is loud, high pitch, bronchiovesicular. It is found over major bronchi in the second and third intercostal space between the scapula, and inspiration is equal to expiration. And there is medium loudness, medium pitch, and vesicular. It is in the remainder of the lungs, which means the vesicular breath sounds are the most common or the most frequently sounds throughout the lungs. And the ratio of inspiration to expiration, inspiration is greater than expiration. So essentially know which one are, whether all of these are considered normal breath sounds, which they are, and which one is the most frequently in the most frequent breath sound throughout the lung, which is the vesicular. So that is what you need to know. Know what are crackles. Crackles could be fine or coarse. They occur at the end of inspiration, and they do not clear. So that is one big difference with bronchi. Crackles do not clear with cough. The quality of the crackles is high pitch, short crackling, and the causes for these crackles could be due to collapse or fluid-filled alveoli open. And the coarse crackles or rales, they used to be called rales, but now it's more commonly called as crackles. So the coarse crackles, they occur also at the end of inspiration, and they do not clear with cough. And its quality is loud, moist, low pitch, bubbling. And they occur due to the same reason as defined, collapse or fluid-filled alveoli opened. Bronchi, no bronchi too. There are two types. There is the sibilant, which are wheezes, and those occur at expiration or inspiration when severe, and they are high pitch, continuous, and they occur when there is blocked airflow, as in asthma. Wheezes are very typical breathing of asthmatic patients. Infections, foreign body obstruction, and the other type of bronchi is the sonorous, and that occur during expiration or inspiration, and they change and disappear with cough. So you ask the person, sometimes you don't know whether it is a crackle or a bronchi, and you ask the person, cough, and the person will cough, and then it will disappear, And if it disappears, that means it's bronchi. Low pitch and sonorous, you could always relate it to snoring. Low pitch, continuous snoring, rattling, and that occurs due to fluid block airways. A stridor is very serious, no stridor, and that occurs during inspiration. And the quality is loud, high pitch, crowning heard without a stethoscope. Even without the stethoscope, you can hear it. That occurs due to obstructed upper airway. Friction and rub occurs during inhalation and exhalation, and there is low pitch, grating, rubbing, and that occurs due to pleural inflammation. So now the abnormal adventitious means abnormal breath sounds. So now the adventitious breath sounds, specifically crackles, bronchi, and stridor. Now, you won't be tested for this bronchophony, egophony, and whisper pectoraloquy during the quiz. But when you are doing your, but you will be tested on this and the final. In the final, you also are not going to. You don't need to perform these tests when you are doing your practicum, but definitely they will be included in the on the final. So when you are auscultating their lungs, there are such thing as auscultation of voice sounds, and this will give you some hints or cues about something that is going on. So bronchophony, during bronchophony, you are auscultating, you have your stethoscope and you ask the patient, say 99. And the sounds, the sounds that you hear through your stethoscope should be muffled. Egophony, ask the patient to say E. So remember E for egophony. So the patient should say E. In normal lung tissue, you will hear E. So you will hear the E, but kind of prolonged. The E sounds like, if the E sounds like I instead of E over areas of consolidation. So instead of saying you hearing or you listening through your stethoscope, E, that is egophony and that is normal. But if you hear A instead of E, then that indicates consolidation. Whisper pectoraloquy, you ask the patient to whisper 1, 2, 3. In normal tissue, the sound will be faint, almost undistinguishable, and muffled, and that is normal. So again, this you can put yourself a little note there that this auscultation of voice sounds are not going to be tested on your quiz, but definitely will be tested on your final. And you do not need to do them on your practicum because it takes time. So assessment of the anterior thorax. Let's see. Maybe we should stop here. Let's see how many more. Oh yeah, quite a few, quite a bit. Do you want to take a break now? Yes.
Can I ask a quick question regarding
Sure.
back to the normal breath sounds?